Our next speaker is Dr. Michael Makdissi. Michael is a consultant sports and exercise medicine physician and Chief Medical Officer for the Australian Football League. He was a member of the Scientific Committee for the 6th International Conference on Concussion in Sport, held in Amsterdam in October 2022. Please welcome Michael.
Thank you, Nick, for putting this together and for the invitation to speak. It's a privilege to be here with you all on a Saturday afternoon, so I appreciate everyone giving up their time. Jacob, thank you for sharing your story, and Jason for really setting the scene about how important translation is into the community. We do a lot at elite sport, and we absolutely need to do more at the community level about recognition and management. My focus is going to be on concussion in sport, so sport-related concussion in particular, and talking about the Amsterdam consensus meeting, which happened a couple of years ago. These are my roles. You've heard a little bit about what I do. I'm a clinician and a researcher, and my research position at the moment is at La Trobe University. You've heard a little bit about me, and what concussion tends to do is it tends to have a fairly diverse audience. So I'd love to know a little bit more about the group that's in front of me here. And you may fit in more categories than one. So doctors in the audience, hands up. Great. Physiotherapists. Great. Other healthcare practitioners. Fantastic. Sports administrators. Great. Lawyers. Media. Terrific. Parents of players who are playing a contact collision sport at the moment. People who are playing a contact collision sport themselves. A few. People who've had a concussion or a head injury. So we do have a real mix. It's predominantly healthcare practitioners, great to see, but we do have a real mix, and that's what these sessions tend to attract. So really what I want to talk through is the 6th International Conference on Concussion in Sport, because that really sets the scene about where does the evidence lie with all of these things. But the critical thing that Jason and Jacob highlighted is how the hell do we translate that into what we're doing in our practice, in our day-to-day lives. This is a really interesting slide looking at a number of publications just on sport-related concussion. When I started, it was back in 2000, easy. It was only a couple of papers that you needed to know about, and that's what's happened over time. So often I hear people quoting a paper or two papers where they're sort of selected from thousands of papers now, and that's rising exponentially. So the expectation for any of us in this room to actually keep up with that literature is becoming increasingly difficult. And the Concussion in Sport group recognised this some years ago, and this is a picture from the podium at the last conference, and there's some notable Australians sitting in the group right here. It's an international conference, varied representation, and really it is to try and work through those thousands of articles to say, where do we sit right now in terms of the literature? So it's purely about the evidence base. The goals of the conference are relatively straightforward, and they have not changed in the time that these conferences have been held. It's about having a simple and clear message and really basic tools that help practitioners making a diagnosis and managing concussion. But the mandate has always been to try and make sure we're using freely available tools so that we can use them worldwide. Doesn't rely on expensive equipment. Focus is on better knowledge translation and improving care of athletes, irrespective of sport, the level, country that they're playing. And so these are the documents. So 2001, so we've had now multiple conferences, and at the end of the conference you end up with a consensus statement summarising all the literature. So the 5 preceding conferences, and you'll see they're usually held somewhere nice, Berlin, Zurich, Vienna, so it's a good area to be involved in. And the most recent conference was in Amsterdam. As I said, it was 2022. But like all of these things, there really is a long lead time, and we started the process in August 2018. Enormous amount of preparation. Obviously, the conference was due to be held in 2022, delayed by COVID like most things. In 2020, but was delayed for a couple of years by COVID. There's a consensus meeting, which is a single point in time, and then there's more writing before you end up with all of the outputs. There were 10 systematic reviews. That's a lot of work, and over 100 expert authors involved in those 10 reviews. And in total, the 10 reviews considered about 85,000 articles, just to put it into perspective. 2-day open meeting, 30 experts, more than 300 abstracts submitted, and more than 500 participants. It was a room like this, a bit bigger, and everything that was said during the conference was considered as part of the consensus. So it really is quite a process. You end up with 2 editions of the British Journal of Sports Medicine dedicated to the conference, with the paper describing the methods, the consensus statement, 10 systematic reviews, and the tools, and I'll talk briefly about the tools. But the ones I've highlighted there are the ones that are freely available. So you don't have to have a subscription to the journal. You can go online and you can download and use those things. Just to give you an idea of some of the things that were covered in those 10 systematic reviews. Now, the 10 systematic reviews address key questions that clinicians are asking. So they cover things like prevention, sideline assessment, and so on. And I'll go through some of these things when I'm talking about it. So having been through that process, what are the key messages? What are we coming back with now that we can use in our practice, in our guidelines, all of those things? Concussion's challenging. You heard from Jacob. Didn't really know what he had at the time. This is a complicated graph from some animal research work done in UCLA. And it shows changes that are happening in the brain over time after a head impact. There's iron changes, there's glucose changes, blood flow changes. So there's a whole range of changes that are happening at different time points. So no wonder why it's complicated. One of the key messages that I want to get across, and you'll see this slide from me a number of times, it's not one thing. We talk about concussion as a diagnosis. But there's usually a few things contributing. There's a spectrum of injury to the brain. There's confounding pathology, so injury to the neck, headache syndromes, migraine type. And there's coexisting or secondary pathologies that all can contribute to symptoms. And it's really important once you start looking at it as, okay, what are the components that are contributing in this particular case? You then start to have a different frame of mind about recovery and treatment. That's really important. A practical definition is important. I'm not sure we've got it yet. This is the definition that was provided in the Amsterdam consensus statement. Don't bother taking a picture of it. It's boring. And it's not helpful to the clinicians. Sport-related concussion is a traumatic brain injury caused by blah, blah. It doesn't actually help you make a diagnosis. The American Congress of Rehabilitation Medicine have realised this and said, hang on, we need something that's a bit more helpful to our practitioners. And so a little bit less complicated, but still complicated, has to be a mechanism of injury, a whole range of things, and you follow that down. And that's a definition of mild traumatic brain injury. At least it's moving in the right direction because it's about being practical. And we've boiled it down to this in AFL, and this is applicable across all of our competitions. You've got to have a mechanism of injury, so there has to be an injury. And as you heard from Jacob, it wasn't necessarily a knock to the head. It can be a knock to the body with that rotation through the neck. But there needs to be a mechanism of injury. There needs to be symptoms or signs. And you heard from Jason as well, the symptoms for most of us are most important here. And that equals concussion, or at least a suspected concussion. So really simple. Mechanism, symptoms and signs that are consistent should be concussion until proven otherwise. You've heard Jason mention about the SCAT-5, now SCAT-6. Not perfect. When people were talking about it, they're sort of talking about it being a gold standard. It's not a gold standard. It's not the optimum way of treating. Often you don't have a baseline. Often you're making that subjective interpretation about what you expect from the person in front of you based on their level of education, their age and so on. It helps having someone there who knows them, like mum or dad or a guardian. The purpose of those assessments that have been developed by the Concussion in Sport group is just to have a standardised assessment. So you're doing symptoms, balance, some sort of brain function testing. So you're trying to test the domains that are affected by concussion. Anything included in there has some evidence base. So at least it's been through the research to say it actually has some sensitivity and specificity in trying to pick up what it needs to pick up. It assists in the recognition of concussion, but also recognition of red flags. So when is it not a concussion and something more serious that you need emergency management? And it assists in the monitoring of recovery. So we've got the concussion recognition tool, and that really is a recognise and remove tool for everyone. The sports concussion assessment tools, so the SCAT-5, now SCAT-6 in a child, SCAT-6, and that really is for healthcare professionals within the first 72 hours. And there's a broader tool now, which is the Sport Concussion Office Assessment Tool, or SCOTE-6 in child, SCOTE-6. And that is a little bit better for monitoring recovery. But again, Jason was talking about the SCAT-6 taking 10 or 15 minutes. The SCOTE, to do it from start to finish, probably about 40 minutes. It's not really a practical tool for general practice or someone dealing with this every now and then. It's more for experienced hands. And most often you won't need it. This is the concussion recognition tool, really basic. Really clear red flags. When does this person need an ambulance and referral to hospital straight away? There's also a head check app developed by the MCRI, and again, that's a recognise and remove tool, easy app on your phone, fantastic tool to be using for recognise and remove. I won't go through the SCAT-6 and child SCAT-6 much, but to say that it is for trained healthcare professionals. That's most useful in the first 72 hours. You can use it after. And there's not a lot of change between the SCAT-5 and the SCAT-6, and that was deliberate because people are used to using the SCAT-5, so we didn't want to change too much in it. But it is a screening tool, and people using it need to understand the limitations. I won't go through the office assessment tool just to say it's a much broader tool. It's been expanded really to include other things that are commonly affected in head trauma, blood pressure, expanding the word lists, making the tasks of balance more complex and complicated to really test the individual, adding vestibular ocular motor assessments to it. considering the mood side of ongoing symptoms, sleep, and a graded exercise test. Recovery is really challenging because it is a spectrum of recovery, and lots of different domains are affected by concussion, and they can recover at different rates. So we talk about recovery, I've recovered from my concussion. When we talk about that, we're talking about everything is recovered. And how we measure recovery, best measure at the moment, symptoms. It's blunt. We know there are still brain changes when people are symptom-free. So what that means, the implication for all of our return to play is we need to be conservative. So we need a buffer. Person recovers, buffer to really start testing the brain at high heart rates, activity levels, and then return to play. You heard this a little bit before, that activity is considered to be an important part of rehabilitation. Rest is important very early, and it's relative rest. It's not a dark room, it's not doing nothing. Reduced screen time is useful, but exercise beyond that early phase, but beyond the 1 or 2 days, is safe, and it actually improves recovery. And exercising with symptoms is okay as long as they're mild, so about 2 on a 10-point scale, and temporary. But we are still relying on symptoms. And more early, the tendency for anyone playing sport is, if you're getting back into activity early, you can return early. But that's not the intention here. And to realise that most of the research on a graded return has been done on physical activity, not so much mental or cognitive activity or return to school. Some individuals need targeted treatment for recovery rather than more time. And that was the point Jason made really well before. If it's been a couple of weeks and we're not getting better or we're getting better slowly, what else is going on? I need to send these to someone who will be able to help. And that comes back to the point of this not one thing, this spectrum of injury, because some of these things don't settle with more time. They need active treatment. All of the innovative technologies were reviewed in one of the papers. And there's a lot that offer promise, whether it be imaging, biomarkers, blood biomarkers, saliva biomarkers, but they all still require some work. It's an area of intense research spending and pressure for a lot of the sports. They might be helpful in our understanding of what's happening in the brain, but at the moment there's no good evidence that we should be using any of them in our standard clinical approach or our standard approach. So I mentioned this before, because we don't have a perfect measure of recovery, there's no scan you can do, there's no blood test that you can do to say, yep, brain is ready to go. We need to be cautious and graded in our return to play. This was the Concussion in Sport Group recommendation for a graded return to play. Again, quite complicated, but the basic steps are day or 2 of relative rest, a period of recovery, that's symptom recovery or clinical recovery, then a graded loading program where you're back in contact or collision sport. If you look at the AIS guidelines that have been released recently, it's the same thing. Rest, recover, graded return. If you look at the AFL guidelines which have just been released, same thing. Rest, day or 2, recover, graded return once recovered. Everyone focuses on, what is it, a 12-day protocol, 21-day protocol, 19 and a half. whatever it is. It's not about the number of days. It's about making sure that we get this right. And this is done with individual activity. I said you can push activity. Yes, you can push activity early, not in a team environment, not where there's a risk of further head trauma, even just incidental. So they're pushing conditioning here. This is when you get into team training. Starting with non-contact training, so incidental contact, building in to full contact training. Recovery varies from days to weeks. So return to play has to be individualised. It can't be a one thing fits all. And so those return to play protocols are not designed to be followed step by step, day by day. Graded, rest, relative rest for a day or two, recover, push activity during that recovery, allow symptoms, graded loading program, no symptoms, clinically recovered, now back into team training. And when you look at all of the guidelines, whether it's NRL, AFL, World Rugby, AIS, they all follow that same pattern. One thing that we don't necessarily do well is talk about psychological readiness to return to play too. So it's a really important one to check that the person is comfortable to return. And I won't talk much about that, but the focus of children and adolescents is really about return to learn before return to sport. So those who fail to progress in their recovery, that multidisciplinary approach is important, again, because there's lots of things going on. Sometimes you need the psychologist, sometimes you need a neurologist, physiotherapist. Combination of it, really important to have those referral networks. So that period of rest doesn't fix all. That those symptoms often have multiple contributing factors, and you've got to look for these to allow a targeted treatment for those things. But that multimodal assessment and treatment is the key. Everyone wants to hear about the long-term complications, and that was probably the most controversial paper in the consensus. But we still have a lot to learn about long-term complications. In the meantime, we need to be cautious and conservative in our approach. In the paper that looked at possible long-term effects, there was limited evidence overall. And there are some criticisms of the paper and the way it was done in that it didn't take into consideration case studies and case series. But even despite that, there's still limited evidence overall. For us, it's important to distinguish CTE neuropathological change, so a pathological diagnosis from traumatic encephalopathy syndrome. So that's people who have symptoms while they're still alive. Often it's just called CTE, and it's thought to reflect both of those things. That's not the case. So where do we sit right now? We know that there's studies in retired professional players in American football and in soccer that do seem to have a higher risk of neurodegenerative disorders when they're older. There's less evidence for mood disturbance and mood disorders. Less evidence doesn't mean there is no evidence. We still don't know, though, whether it's concussion, repeated head trauma, or a combination of both. We still don't know what the other risk factors are. And we still don't know how common that diagnosis is. Decisions about when a player should retire from sport shouldn't be made lightly. Everyone talks about number of concussions, and it's not about absolute number of concussions. It really is looking at a comprehensive assessment of the player with someone who has expertise in both traumatic brain injury and sport, and really trying to make an informed choice about potential risk versus benefit of continuing sport. Important to have the discussion with the athlete to answer any question and dispel any misinformation, use simple language and document it carefully. Just finish off on prevention, and we really need to have a broad focus of our safe participation in sport. What's safe participation? Well, it's good management of concussion. Recognise, remove, refer for a medical assessment, and a cautious or graded return to activity. That's our good management of concussion. But we also want to reduce the number and the magnitude of head impacts and concussion. We need a broad approach to that. It's about training. It's about individual style of play, risk. It's about skills training, especially tackling skills. It's about strength training, possibly neck strength in there. It's about active warm-ups. It's about rules, rule changes, rule enforcement, and protective equipment as well. So leave you with a couple of key resources, and these are easily available online. The AIS, or the Concussion in Australian Sport position paper, and that's really useful. Whether you're an athlete, parent, teacher, coach, healthcare practitioner, there's a section in there for everyone. And we've just released through the week our AFL guidelines that really apply to any level below our AFL and AFLW. And I'll stop there. Thank you.
Are there any questions for Michael? Remembering that there'll be a lengthier panel discussion this afternoon at the last session. No questions? Yes.
Thank you, Michael. I had a question about biomarkers and imaging. There was Angus Brayshaw, who retired, and I'll mention that because it was already in the media. So I was interested that in the media they mentioned that he had brain changes on imaging and how, I'm not asking about him personally, but is the AFL interested in imaging? Because from what I heard, it's we don't know yet, like what's actually helpful from an imaging point of view. Yeah, I'm not asking about his personal case, of course.
So, of course, I can't comment on the individual case, but yes, we are interested in imaging. So when we look at structural neuroimaging, so standard structural imaging that you've got at the moment, more often than not, it's either normal after a concussion or shows some incidental findings. You can only assume that in Angus's case there was something else on the scan that tipped the balance in favour of making that retire recommendation. There's lots of newer scans and lots of newer images that we are also interested in, but these things have a massive impact on the players, and if you're not really sure what it is that you're dealing with, so for example, if we did a scan and found something, then how you translate that to the individual who's making, and I'm just talking about elite athletes first, it's a really difficult decision to say, well, I don't actually know what it means. Are you going to play? Don't know. What does it mean if and the athlete rightfully asks, what does it mean if I continue playing? I don't know. So we still need a lot of work in that area. And so I'm really supportive of it, but in a very cautious and careful way to make sure that we're clear about what we know and what we don't know.
Thank you very much, Michael. I've been a physio for almost 30 years, and I remember in the early 90s sending players back on that were clearly concussed and pulling them back because they were running in the wrong direction. So thank you very much for the work the AFL are doing. I was part of the APA working group that contributing to the IAS statement, so I'm very familiar with that. Just getting my head around the new AFL guidelines that were released a couple of days ago. My question's around the recovery phase where the AIS document, I think, allows 14 days to get to that maximum heart rate symptom-free at rest. The AFL have moved to a 7-day period where they need to be maximum heart rate at rest and in that intense high-level physical activity. I was just wondering if you'd expand on why you chose to move from that 14-day period to 7 days, please?
There's some slight differences between the two protocols, but essentially they're basically the same. In that, what we try to do is that's a minimum when you look at it, and it is so that recovery phase. The critical part of that recovery phase is just grading up activity, and we're really comfortable for that to be pushed early. You cannot enter the graded loading program until you've recovered fully. The slight difference with the AIS is you only need to be symptom-free at rest. And that's what we want, is full recovery at rest and with activity before you enter the graded loading program. So we actually want full clinical recovery. Ultimately, they're nuances of the same message. They're very similar aspects of the same message. So it doesn't change. I don't think it's going to change the outcome too much for the athletes.
We have time for one last question. Tony.
Thank you. Thanks for that talk. That was really very, very enlightening. But on that last slide, you had helmets. And I'm already fielding questions from mums of junior boys. I still don't know. At an empirical level, I don't know how a helmet's going to stop a contra-coup injury.
Yeah.
But what's the evidence? And is a question for later on?
Yeah, thank you. The soft shell headgear that's available for our contact sports in Australia are made to a standard set by World Rugby some time ago. And in all of the studies where you look at it, they don't seem to prevent concussion. We have less data on actual head trauma, whether it actually reduces number and magnitude, but it probably doesn't make a difference. As you say, how can it make a difference necessarily to that, to the rotation and that coup contra coup injury? We think that there's still a lot of work to be done on soft shell headgear. We think that there's some new innovative designs and materials that might actually make a difference, that attenuate impact but also reduce rotational forces as well. And there's still a lot of work to be done, but we've changed the standard in AFL, so we've rewritten the standard, and we're now asking some manufacturers to make helmets to those new standards, then we'll test them. So once we've got at least some lab testing looking at that, we'll then probably do an in-field study. So we're still a long way, but at the moment, we don't have a particular recommendation about helmets. We say there's no evidence for use, but we don't discourage people who want to use them from using them. But we're actively involved in sort of that next generation. Can we actually find something that does work? And I don't know, hopefully in a couple of years I can stand here and tell you, yep, there's all these helmets now made to a different specification, different materials that do work.
Can you please thank Michael?